So welcome, everyone. Today we're doing another Facebook Live session for COVID-19 and SADS conditions. So today we have Dr. Mike Ackerman and Dr. Ray Woosley. So Dr. Ackerman is the genetic cardiologist at Mayo Clinic, and Dr. Woosley is the president of CredibleMeds, and he is out of Phoenix, Arizona. And before we get started, I didn't know until about 30 minutes ago, today's National Doctors Day. So fun fact. So thank you guys for everything that you do and all the doctors. Can you guys hear me okay?
Yeah, I can hear you great. Thanks a lot.
No, great. I'm just checking. Okay, so this Facebook Live session will be posted on our Facebook page, and it should be available for you to view, and then it'll also be posted on our SADS YouTube channel. All right, you guys ready to get started?
Ready to
Sure.
go.
Okay, so our first question is for Dr. Ackerman. Somebody asked, is long QT syndrome considered a heart disease? They keep saying that having heart disease puts you at a higher risk for COVID-19. They're also asking if you could define high risk, and if it means if you have a higher risk of contracting the virus, a higher risk of getting more serious symptoms, or a higher risk of dying.
Great. Aaron, thanks. And before I get started with that great question, I just want to thank everybody for joining us at the SADS Foundation. It is just really special to be with you all again today. Sorry about last Friday's technical difficulty, but this is our second one, and there will be more to come. And on behalf of Alice Laura, who's the CEO of our SADS Foundation, I am really enjoying trying to do our best to help you all out and help us out at the same time. As you know, I get to serve and have served as the president of the board for the SADS Foundation for many years now, and it's just a real treat to have Dr. Ray Woosley join us. And he has been a vital physician in our cause for the SADS Foundation, making families with long QT syndrome and physicians who take care of families with long QT syndrome be aware of the potentially dangerous QT prolonging medications that are out there, and there are many of them. And so, Ray, thanks for joining us. I'm really glad to have you, and I'm looking forward to our next 45 minutes together.
Thank you, Mike. It's a pleasure, and thank you for all you do, and Alice and her entire team.
So to Aaron, your question, is long QT syndrome considered heart disease? The short answer is yes, but not the ones they're talking about for COVID-19. So of course, long QT syndrome, CPVT, Brugada Syndrome, are SADS heart conditions, are heart conditions. They are heart diseases. And the difference is, and what I was really concerned about 2 weeks ago when that paper came out, saying that people with heart disease are at much greater risk of having COVID-19 serious expression or serious disease expressivity, is that not all heart disease is the same. And so for the vast, vast majority of long QT patients where their only heart disease is long QT syndrome, they are not at increased risk of COVID-19. Now, any person, whatever your health status is, as you get older, you are at greater risk. So we know COVID-19 has been harshest on the elderly. So elderly individuals with or without long QT syndrome, with or without any condition, are at greater risk than individuals who are 40 years of age and younger. So long QT syndrome is heart disease, but it is not one of the higher risk heart diseases for serious COVID-19. Those heart diseases are patients with heart failure, patients with coronary artery disease, patients with prior myocardial infarctions. And so the highest risk group are older individuals who have one of those kind of heart diseases, not young individuals who have SADS conditions like long QT syndrome, Brugada syndrome, CPVT. Overall, our families are at much lower risk. Our families with genetic heart conditions that are on the heart muscle side, so genetic dilated cardiomyopathy or genetic hypertrophic cardiomyopathy, where the heart muscle itself, not the electrical system, but the muscle itself is intrinsically diseased, those individuals are at higher risk, but still not as high of risk as an elderly person with a prior myocardial infarction or an elderly person who has heart failure with reduced ejection fraction.
Great. Let's see. Okay. All right, so the next question is for Dr. Woosley. So there are lots of questions about new COVID-19 medications, specifically chloroquine and hydroxychloroquine. They are asking if you could address this and the QT/TDP risks and high-risk populations, and also the medication remdesivir.
Thank you. I think that, as Mike pointed out, that long QT patients aren't at higher risk of getting COVID, but if they do get it, they're at greatest risk because of some of the treatments that they might receive. And I'm not just referring to chloroquine and hydroxychloroquine, but a lot of the patients with COVID have nausea, and a lot of them are likely to get medicines like ondansetron, which are also a risk. But to answer the question, there's a lot of people who've heard of the reports that chloroquine and hydroxychloroquine might be effective, and a lot of people are taking these, and these drugs are known to cause torsade. We know they prolong the QT, and they've been on our risk list for at CredibleMeds for some time. Hydroxychloroquine was recently changed, but it's on the known risk list because there are clear cases of torsade de pointe associated with it. There are clear cases, evidence of QT prolongation, and there's strong warnings in the FDA label that these drugs can prolong QT, cause torsade, and also cause cardiomyopathy, other cardiac complications if taken longer. But I think we've always said to patients with long QT, be very careful of the medicines you take. And this is one of those environments where you may need some of these medicines, and we really need to have the evidence that they're going to be beneficial. They definitely have not been proven or even evaluated carefully for prophylaxis, for prevention of COVID. And the data on their effectiveness is very soft. The studies that have been in the press have been, in some cases, not yet peer-reviewed. The evidence has been looked at carefully, and there have been a lot of dropouts from those studies that weren't part of the publication, and they were uncontrolled. So the evidence we have is worthy of investigation, but it is not, to my mind, evidence that it will work, and it should only, those medicines should only be used in clinical investigations where we will learn whether they're working or not, or in the most dire circumstances. And Mike, you were mentioning the FDA has given them a special status today, so maybe you want to elaborate on that. But that's my feeling about the, well, I should make one other comment. A lot of people are combining hydroxychloroquine with azithromycin, which is a very safe drug, but we know it prolongs QT in some people. And we would predict that combining azithromycin with hydroxychloroquine, both drugs that prolong QT and both which can interact to cause interference with each other's elimination, are a very dangerous situation for anyone, but especially for patients with congenital long QT.
Great. Mike, did you want to kind of go into—
Thanks, Dr. Woosley. Thanks, Dr. Woosley. I think what Ray was referring to, everyone, is that this morning the FDA and the Health and Human Services announced an emergency use authorization, or an EUA, for the use of chloroquine and hydroxychloroquine, whether inside or outside a clinical trial, if the physician felt that it was in their patient's best interest to try that COVID-19 therapy. So the concerns that Ray and I have raised about these therapies and the QT interval and the possibility of drug-induced sudden cardiac death are going to be more important than ever because they're going to be used more and more. I hope there's therapeutic efficacy. I'll wait to see Dr. Fauci and infectious disease experts come to conclusion about that. But in the meantime, they're being used, and we need to make sure that they're used safely. And so that was one of the reasons some of the people who have joined us may have seen already. We published in record time an urgent special article about these proposed and used COVID-19 pharmacotherapies and the QT issue, not just for long QT patients, but for all patients, because we will see drug-induced sudden cardiac death if these drugs are not used wisely. And so we put out a green light go, which would be the status for 90% of all patients, where there's going to be plenty of safety margin with the use of both of those drugs together. There's going to be 5 to 10% where it's going to be yellow light, pause, proceed with great caution. And 1% of all patients, not long QT, all patients will get a red light status before their first dose. If they were to know their QTC, where we would say, stop, be very, very careful, because we are moving closer and closer to the edge. And we will have a perfect storm if we don't take preventative measures to short circuit. You heard Ray ask, are they already on other QT prolonging drugs? If yes, can we stop them? We better stop them if at all possible. Are their electrolytes normal? If not, we better make their potassium normal, their magnesium normal. But that we can do all of these preventative measures. And so it doesn't mean that if you have genetic long QT syndrome, that there's no way that you could ever get these medications, because that will ultimately depend on risk benefit. How good is the benefit? We don't know yet. We do know what the potential risk is, but that risk isn't the same for every long QT patient. A person with long QT1 who has a QTC of 420 isn't the same a priori risk before they would get the medicine as a person who is long QT2 and their QTC before drug exposure is already 550. Those are going to be two very different long QT patients with two very different possibilities of drug-induced sudden cardiac death.
And also, there was a question about remdesivir. There's several antivirals, excuse me, being used, and remdesivir is one of them. There's the combination of lopinavir, ritonavir, which I think is brand name Coletta. There's another one that's not, a couple of others that are investigational antiviral drugs. These drugs have not been evaluated for QT except in one case. I think that was famdesivir. It was negative. The others have not been tested for their effects in normals. Now, I always point out that those are studies performed in normals, and they don't include people with congenital long QT. But so far, those drugs look, the antivirals, like remdesivir, look like they are probably not affecting QT. The other caveat is there's no evidence, as is with hydroxychloroquine, there's no evidence that they are effective for COVID yet either. They're being tested. There's actually a negative study that I saw on remdesivir, but this is, things are evolving quickly, and I think there's a lot of antivirals being tested. Hopefully one of these will work. I always go back to the HIV epidemic when we were struggling to find drugs, and everyone went to the cupboard and they found AZT. And it wasn't a great drug, but it was at least something that could be used in the beginning. And eventually we found very effective drugs for HIV, and we'll do the same for coronavirus, I'm sure. But it's going to take careful evaluation of these therapies, not overzealous use, especially for prophylaxis, because a lot of people won't get this illness and or will have a mild case and will not justify being treated.
Great. And there was a follow-up question about some medications. It was asking if somebody could use Plaquenil and Azithromycin in a hospital setting.
Yeah, we answered that, Aaron. So Plaquenil is hydroxychloroquine, just for everybody, and azithromycin, trade name is Zithromax. So I think Ray would agree is the use of both of those medicines in the hospital setting will depend on what kind of long QT patient we're taking care of. For example, if we're talking long QT syndrome specifically, high risk long QT patient, low risk disease, they probably aren't even hospitalized in the first place. They better not be put on both of these medicines. Low risk long QT patient, COVID-19 is misbehaving in their body badly, then we probably can use both of these medications as long as we're carefully monitoring.
I think that's the key word is observation, monitoring, careful use. In these dire circumstances, sometimes we have to take drastic measures, and you just do it as carefully as you can. You don't do it cavalierly. You don't react in ways that are illogical, like taking a medicine for something that doesn't exist.
Great point.
Okay, the next question is for Dr. Ackerman. Somebody asked, I've heard that COVID-19 patients are getting continuous albuterol. Is this safe for long QT syndrome? Should my daughter be using her albuterol as needed now when she's not sick?
Great question. First of all, I think the whole connection between albuterol and long QT syndrome is incredibly weak. So overall, albuterol, which is your puff inhaler that you use for your asthma, doesn't get to the heart very much at all. The reason it's flagged is because it's adrenaline-like, and we have concerns raised about adrenaline. But I have lots of long QT syndrome patients with concomitant asthma. Asthma is present in 7 to 10% of the planet. So you can imagine we have 10% of our patients with long QT syndrome who have asthma. If they are having asthma disease and they need to be taking their albuterol inhaler, by all means, they should be. But that patient that the mother's talking about for their daughter, if she's not having asthma right now, she shouldn't be taking her albuterol at all right now. The reason why the continuous nebulizer treatment or albuterol is being used in the COVID-19 patient who's hospitalized is because they're not doing well. They're not moving air very well, and they're doing everything they can to try to improve oxygenation. And if my long QT patient got COVID-19 and was bad enough to be hospitalized, and the doctors thought that they needed to use albuterol, I would not be QT afraid at all. Ray, any comments you would add on that?
Oh, I'd love to comment. This is something that you and I and our advisory board have struggled with a lot. We hope the drugs to avoid list is helpful, but when we put the drug list together, we add the caveat, these are drugs to avoid unless they're necessary. And we took the position of extreme caution. Theoretically, adrenergic drugs that are like adrenaline, can worsen some patients' arrhythmia with congenital long QT, but not all. And as Mike said, many of the doctors who treat patients with long QT syndrome use these drugs regularly and effectively. But always remember that list is a list to consider when you have congenital long QT, and many of those drugs may be necessary and are often necessary. And we've been working with Alice and Mike and others to try to come up with evidence that would help us know which long QT genotype might be adversely affected by adrenergics or other subcategories of drugs. And we just don't have that data yet. So we have to say, here's a list, a lot of medicines that you should avoid if possible, and if absolutely necessary. You could take these.
Great.
Great point.
Okay, so the next questions are related to stress surrounding COVID-19. So let me just scroll down. Okay, so this first question is asking about the effects of mental health related stress during the COVID-19 crisis and long QT type 2, and maybe all other types of long QT syndrome.
Well, I like the question because there's plenty of stress out there right now. Everybody's feeling it. I loved, and thank you to one of my patients out there who sent me a picture of #refuse-to-fear, which she heard me say. And I love that because I still, even now that we are seeing the numbers climb, I'm still in the refuse to fear. I don't see any value in fearing. I see value in knowledge and power and sound mind and love and peace that passes all human understanding. But I don't see anything valuable that comes from fear in that sense. And we do know that stress is not good for any patient's heart disease overall. The concern raised about mental health related stress is that patients with type 2 long QT syndrome, which our SADS families probably know is the one where doorbells, alarm clocks, auditory triggers are more long QT agitating than sprinting down the road, which would be more in LQT1. And there's suggestion that patients with long QT2 may have more concomitant mental health, anxiety, stress, baseline issues. And so sure, stress is not good. It's not good for LQT1, LQT2, or LQT3, or CPVT, or any of them. And all of our families should be doing all things that you need to do to keep some semblance of calm, of confidence in this midst of this crisis, of togetherness, of connectivity, a lot of things that you need to be doing. For me, one of my life verses long before coronavirus and COVID-19 is, for he, Jesus, has not given us the spirit of fear, but one of power, love, and a sound mind. So I'm choosing to operate in those, and I'm refusing to operate in fear.
Thank you, Mike. Could I jump in and say I agree completely. I think we want to rely on our faith, rely on our science, and keep a positive attitude about this, because we will get through it. Sadly, a lot of people will be harmed. We know from previous stressful periods that sudden death peaks during those times. I actually have had 2 people I know in their 60s who've had sudden death in their sleep this week. So I fear there's going to be a lot more of this. So I think your message, Mike, is one that we need to also get out, that there are very strong incentives in taking a calm approach to this.
Absolutely. Okay. So there is another question going back to albuterol specifically for CPVT. I'm not sure if there's anything else you'd want to touch on that with Mike for CPVT.
No, I think for our families out there with CPVT, catecholaminergic polymorphic ventricular tachycardia, I have the exact same guidance. So albuterol is, as Ray said, is not QT prolonging directly, it's adrenaline stimulating or mimicking. And so we know in CPVT that adrenaline is the common denominator trigger for most CPVT triggered events. And so if you didn't need albuterol, you don't need to take it. But if you have asthma and your asthma needs albuterol bronchodilator puff inhaler therapy, I have no fear about my CPVT patients taking their albuterol. None whatsoever.
Great. Okay. So you can both answer this. I'm not sure who would like to answer it first, but there's a question asking, is there a credible source to point our own cardiologists or physicians to for guidelines to treat someone with a SADS condition who comes down with COVID-19?
Well, there are guidelines. Well, there's not guidelines, but in fact, we are going to do a special SADS Facebook Live in just 4 days on Friday at the same time, where I'll be interviewing the senior author of an article, Dr. Arthur Wilde, a dear friend of mine, and many of the SADS families know, from Amsterdam. And he and his team, like we, put together an urgent article for all the globe for the QT issue and the COVID-19 pharmacotherapies, Arthur Wilda's team put together a specific article just for SADS families. So for families with inherited arrhythmia conditions, that what are the key considerations to be focused on if they were to come down with COVID-19, and how could their healthcare teams treat them. That paper just got accepted in Heart Rhythm. It hasn't been published yet. It should be published anytime this week. And we'll be interviewing Arthur Wilda here in 4 days. But it's basically the same thing we talked about a week ago Friday for all of our families. If you get a fever from the disease, you should be lowering the fever. And if you have nausea and vomiting, you should be staying potassium replenished and so forth. But we will talk specifically during that whole time about what Arthur Wilda and his team put together for specific guidance for each of the genetic heart rhythm conditions. And that should come out in print, in online publication real soon this week. And we'll be interviewing him this Friday.
Okay. Was there anything you'd like to add to that, Ray, or did you kind of cover all of it?
No,
Okay.
look forward to reading that. Mike and Arthur will really have a good opportunity to provide some guidance and wisdom for those docs.
Mm-hmm.
I think what's incredible, Aaron, and Ray and I have been watching this in real time. I have actually never seen the field move at such unbelievable speed at all sectors, from government to science to medicine to hospital and to publications. I mean, papers that generally take months to make it through the process. These journals and their editors and the publishers have stepped up to the plate in a big way to recognize the urgency of the situation before us, that we don't have months for these papers to appear online. They literally need to appear in days. I mean, people won't believe it, but it's the truth. From the moment our team conceived of our special article about guidance for COVID-19 pharmacotherapies and the QT issue, from conception of the idea to published online, 144 hours, 6 days beginning to end. And Ray and I are witnessing this in many, many fronts. Ray, maybe you want to comment about how rapidly you and CredibleMeds got out some urgent guidance to thousands and thousands of physicians through your connections.
Yeah, it's been a remarkable experience, and it's a terrible thing to have to go through with COVID, but we're just fortunate we have the technology and the ability to communicate as rapidly as we have. We've sent out 75,000 emails yesterday to practicing physicians and pharmacists who have registered on our CredibleMeds website to receive updates on QT, and the number of registrants is skyrocketing. The number of visits to our website is skyrocketing. So I think Mike and I are happy that people are becoming aware of QT, but we're not happy with why. We've been able to get the word out. We've gotten very positive feedback. People are eager to get this information. They want to do the right thing. They're concerned about the unknowns that are out there. And I think that the ability to communicate and the ability to share science is going to help us get through this better than any epidemic we've ever faced.
And I really appreciate, Ray, you and your colleagues in CredibleMeds, www.qtdrugs.org, because you also linked your people immediately to our article and to our algorithm, because it's not difficult. But the reason we did this paper is, starting 2 weeks ago, Ray and I were observing craziness in the social media among healthcare providers, which range from QT cluelessness, you mean there's a drug-induced side effect issue, to QT resignation. In other words, yes, it does this every once in a while, but if these drugs work, we'll just call that the friendly fire. of these drugs in the battle to QT paranoia and hysteria, thinking that these drugs are so dangerous they're going to kill everybody. And none of those three things are anywhere close to the truth. And knowing the truth, it'll set you free. And we felt we have got to get some balance and order in this, because there's the right way to do this. And if these drugs work, still if, we can figure out ways to navigate the QT issue and not accept friendly fire as just collateral damage, but be sure we can administer these drugs as safely as possible. And those who are at higher risk, introduce even more countermeasures to make sure we have as much QT and drug-induced sudden cardiac death safety as possible. And I think we're seeing everybody unite in the ability to do this and the effort to do this at literally warp speed.
And Mike, you have to really be applauded for the work you've been doing with Cardia and AliveCor. And you probably don't want to promote it, but I do, because one of the real challenges we've faced for a long time in talking about QT is the fact that to monitor QT in the past, it's meant you have to take your clothes off, you have to go to a doctor, you have to lie down, you have to have wires attached to your body, you have to pay $150 or more for an electrocardiogram. Now with the Cardia device, it's really possible to monitor QT for pennies. You can do it effectively in patients who are in a hospital environment without having to send them or send an EKG team in to risk their exposure. So the technology that's available because of your hard work, Mike, is going to save lives and help the docs that we want to honor on Doctors' Day, and the other healthcare providers that go in with those docs to rooms that are a war zone and a threat to their lives. But now with the Cardia device, you can obtain an electrocardiogram without all of that expense and exposure. And that will save lives, I have no doubt, and you should be proud.
Thanks a lot. We hope it's a game changer and a lifesaver. And we did mention, and Aaron, you mentioned at the outset, National Doctors' Day, which I think might be tomorrow, but regardless of its day, the real people that we, Ray and I, as fellow physicians, honor are the nurses on the front lines, the respiratory therapists on the front lines, everybody who is doing all the hard work called not an MD, the nurses and respiratory therapists and the custodians who are going in and cleaning the rooms. These are the heroes, and we join them, and we're grateful to all of them for what they're doing.
Yes. Okay.
Yes.
So just a few more questions about specific conditions. There are some questions asking, what about Brugada and the COVID-19 drugs or medications?
Right. So for Brugada syndrome and our Brugada syndrome families out there, the good news is if these COVID-19 drugs work therapeutically, there's no signal that they are Brugada aggravating. So that's the good. We do know that importantly for Brugada syndrome, and Arthur Wilda will expand on this on Friday, is that Brugada hearts don't like fever. So if the disease is resulting in fever, like any febrile illness, influenza, anyone, nothing special, fever is fever. Brugada patients with fever, lower fever. And probably lower fever in the case of COVID-19 with acetaminophen, Tylenol, rather than with ibuprofen or Advil. I'm still not sure what I think about that concern about ibuprofen and Advil for COVID-19, but until that is all figured out, I would lower fever with acetaminophen. And so for Brugada patients, I think they're going to be in really good shape overall.
Great.
Ray, do you have any comments on that? I know Ray has partnered with CredibleMeds. We have another website that is really maintained by our group in Amsterdam, www.brugadadrugs.org, for those medications that we know to be Brugada aggravating. But I'm pretty sure that the treatments being considered are not on the Brugada drug hit list. Do you know for sure, Ray?
I'm almost certain. I'll verify that, but I think you're right that they're not. I would pass on an observation that the usual doses that are being used are probably not likely to be a Brugada threat, but I did see the electrocardiogram of a patient who took a tablespoon of chloroquine, the patient who was supposed to be putting that in their fish tank, and they had evidence of QRS prolongation. So in massive doses, this drug is a multi-channel blocker, and it might be in excessive doses a problem, but that's theoretical, and I don't think they're on the Brugada list at all.
Great. Okay, now we have some questions regarding AliveCor. So somebody asked, if we currently have an older Cardia device, what do we do? Will a AliveCor device be available outside of the US?
Yeah, so I'll start and then I'll let Ray expand. But Ray mentioned the reason he acknowledged it is we at Mayo Clinic have been engaged with AliveCor long before coronavirus. So this is pre-corona existence, which seems like a lifetime ago already. But we started with AliveCor in 2017 because people like Ray and myself saw a value in a mobile QTC monitor solution. I personally believe that the QTC is the next vital sign. I want to know a patient's QTC every bit as much as I want to know their blood pressure or their O2 sat or their weight. And so this partnership with Mayo Clinic, with some of us as the co-inventors, was moving along well. We were close to FDA submission for a direct indication for the AliveCor CardioMobile 6L device to also have an FDA indication as a QTC monitor. That got fast-tracked about 10 days ago when the FDA granted emergency approval for AliveCor's CardioMobile device to be used for QTC monitoring for COVID-19. And so that device is there, it's available. Physicians still have to measure the QTC off of it. We are working as fast as we can to have an automatic QTC value flash up when the AliveCor trace is obtained, and potentially even link it to our action steps: green light go, yellow light pause, red light stop. But that's technology that needs to yet be built into the AliveCor CardioMobile brain, and we're building that into the brain as we speak. But one could order the device, anyone, anywhere can order the device and have their physician look at and measure the QTC off of it. Because one of the things that's really easy is anybody in a split second, if your physician stares at that AliveCor tracing, and if the QT interval is less than half of the RR interval before it, you immediately know that the patient's QTC is below 460 and they're in the green light go territory. And so you can, whether it's on the telemetry, our nurses and ICU people, we can figure out in a split second whether that patient would be in the 460 or under green light go category. So it is available. Ray, maybe other comments. You're very familiar with what we're envisioning, even pre-corona, could be the use of this kind of smartphone enabled mobile ECG device for our patients in psychiatry, for methadone users. There's a long list that was being generated long before coronavirus. Ray, your thoughts on what you were envisioning as the future before this all happened?
Well, you're exactly right. We've actually used the 2L device in research and have a publication pending right now with it, where we were able to use it in an MRI facility to monitor QT. We envisioned and have worked with, I actually did a study with Dave Alberts at Cardia where we compared 12 lead QTs to QTs measured from the 2L device and found 100% correlation. So we have no doubt that it's just as good and a lot easier to obtain. The other aspect of this that I would point out is getting the QT is part of a sort of a three-legged stool. You got to know your patient, you got to know the QT, and then you've got to know the amazing amount of information to manage all of that. And that's where Mayo was one of the leaders. They took our QT drug list and they developed a decision support tool that runs in their EMR, their medical record, electronic medical record. Indiana did the same thing. Denver has done this. We've done it now in Arizona in a hospital, a chain of hospitals in the Southwest, where the electronic medical record takes the QT data and the drug list and advises doctors on how to manage that. And that's the future, I think. Everybody will have a system to help them understand how to use QT data, but you've got to be able to get it quickly and efficiently. And that's what Cardia does, is the first step in enabling.
So it's amazing, isn't it, that here out of, I mean, and of course we are in a pandemic crisis. No one should be sugarcoating it. We all should be doing it. Obviously, this interview is being conducted in our rooms because we're taking physical distancing seriously. We're washing our hands more than ever. So we are in the midst of this battle, but once we win it, and we will win it, I have no doubt, we are actually going to save way more lives for all kinds of other reasons, from all the things that we are rapidly learning together from technology sector, pharmacology sector, innovation sector, artificial intelligence, healthcare team delivery. I mean, even envision the future, which has been in Ray and my dream future. I think it's a reality, and that future is you walk up to your pharmacy, you put your fingers on your cardiomobile device on the counter of the pharmacy, and before they dispenses that medication that is known to have a QT prolonging signal, whether it's hydroxychloroquine, Azithromycin, ondansetron, or any of the 100+ FDA-approved medications, you get QT cleared. And if you get QT red light flag, there will be a pause built into that where it'll be not so fast. Maybe there's some due diligence we need to do, and that will save lives. So ultimately, through this crisis that we're in, there are going to be some life-saving discoveries and innovations that will be made that will help all of mankind going forward. And we will eventually have good COVID-19 therapies, and hopefully those COVID-19 therapies won't even need that green light go because they don't even have a QT signal. And that would be, I think, the ideal outcome of this. We don't like that we have to have this QT intervention right now, but the reason why it's urgent is because the drugs that are being used in the absence of true evidence, hydroxychloroquine with or without azithromycin, are being used a lot. And with FDA's emergency use authorization this morning, they're going to be used even more during these next 1 month, 2 months, 3 months, until the answer is out about do they actually work. And so we need to step in to make sure we don't have any more so-called QT deaths as friendly fire, and keep that number as minimal as we possibly can.
Mike, that's a great point. One of the benefits could be just risk management in general. Everything we learned about how to manage QT risk should be applied to risk with everything we do in medicine, especially the drugs. And so I agree with your point completely.
Okay, I think that is all the questions we have for today. Are there any closing statements or anything either of you would like to add?
Ray, before I bring it to a close, maybe let you just take as much time as you want to express your thoughts, your observations, your recommendations to our SADS families out there.
Well, thank you, Mike. It's been a pleasure to be here. I thank SADS Foundation for the invitation. I probably would start with your message earlier. Everybody keep the faith, keep their calm, don't panic. Seek medical advice when it's appropriate. Don't overreact and take risks that aren't justified. Rely on your healthcare providers for advice. I would think for the patients with long QT and the families with long QT, always be vigilant, but especially at this time when the risk-benefit ratios that we used to deal with are no longer valid. We have new risks, and we're probably going to have new challenges, and we're going to have to operate without a lot of known benefits sometimes. So use our resources that we have, use the devices like Cardia, use our QT drug list, give us advice on how we can make that information more valuable, more useful to you. Know that there is a smartphone app and that's available free to anyone who wants it, to keep a list of the medicines that we know are on a Torsade or a QT risk list, and those are available. Let us know if you have questions. We're eager to answer them. We try to answer every question we get, and we're here to help. And we really thank you for your interest in this serious problem, and we hope you and your families get through this with no harm at all.
Great, thank you so much. And to our SADS families, I just add the same. And I'm particularly grateful, Ray, to you and your team. And I think the number of lives saved from your QT drug hit list, we'll never know. And that's the whole point of these interventions, that if we do it right, we won't know how many near misses were out there, how many perfect storms were about to coalesce and happen. But because of QT respect and QT awareness and consulting, the www.qtdrugs.org, that physician and that team decided not to start something, or they decided to fix the potassium before they started something. And as a result, the condition was able to safely continue to be treated, and nobody gets to know just how close was Torsades around the corner. And so we'll never know, but what we do know is that your website has been life-saving, and so thank you for all of your work. And I leave the SADS families, we will join you this coming Friday. Arthur Wilde from Amsterdam, Netherlands, one of my dearest friends, will be talking to us as senior author of his special article on inherited arrhythmia conditions and COVID-19. We'll give you the latest right from their perspective. We'll take your questions, but I still, a week later, I remain in the refuse to fear category. I remain to believe that perfect love casts out all fear. And I leave you with one of my other favorite life verses: be anxious for nothing, but in everything, by prayer and supplication, let your requests be made known to God, and may the peace that passes all human understanding keep your heart and your mind in Christ Jesus. I live by those. I cling to those. I cling to them when things are going well. I cling to them in the foxhole. And wherever you're at in your life, it's not a bad thing to cling to, because being anxious for nothing is a great place to be. I wish you all the best, and we wish you safety and protection for you and your families. And just know that the SADS Foundation, we're here for you, and we love you, and we care about you very much. And for my own patients who might be listening in, who are my long QT patients, my patients, know that I have you blanketed in prayer daily for your protection. We all love you, and we will all get through this together.
Absolutely.
Thanks, everyone.
Thank you both so much for joining us. This will be posted on our Facebook as well as on our website and YouTube, and we will be joining together on Friday to talk with more specialists. So thank you both so much.
Yeah, thanks a lot, Erin. And we better keep you now, because you're getting really good at this, and so other news media outlets are going to be trying to grab you. So just stay put, Erin. Stay with us. So take care, everybody.
Thanks, you guys.
Bye now.
Bye, everyone.